Good afternoon, everyone. I'm Neil Love from Research to Practice, and welcome to Year in Review. As today we talk about the management of acute myeloid leukemia with Dr. Naval from the Department of Leukemia at the University of Texas MD Anderson Cancer Center in Houston, and Dr. Courtney DiNardo, also from the University of Texas MD Anderson Cancer Center Department of Leukemia. If you have any questions or cases you'd like to run by us, just type them into the chat room. We'll talk about as many of these as we have time. We put a 1-minute pre-meeting and post-meeting survey in the chat room. If you take that, you'll get a lot more out of this exercise here today. If you're into audio programs, check out our Oncology Today podcast series, including a recent program with Dr. Sohn on AML and MDS. Well, we're getting ready to head out to Washington, D.C. for our annual trip to the Oncology Nursing Society. We're doing 11 programs this year. If any nurses watching tonight or you work with nurses who might be interested, please have them check it out. It's always a great experience to work with them. We're then heading right out to the AUA meeting, and we'll be doing a program out there on prostate cancer, and then a virtual program right after the meeting on bladder cancer. Then we'll pick up with Year in Review with targeted therapy in non-small cell of the lung. But today we're here to talk about AML. And wow, it's interesting to even contemplate covering what's new in AML in an hour, but we're going to give it a shot. As we do in all of our programs in the Year in Review series, I met with each one of the faculty individually over the last couple of weeks and recorded a presentation and an interview. They're in the chat room if you want to look at them afterwards, and we'll be sending it out by email along with the recording of tonight's webinar as well. So we're just going to pick up some of the things that were discussed in these two great comprehensive presentations. Here are the papers that were discussed. We're not going to go through all of them. These talks go through them in detail, and also we talk a lot about the clinical implications and some of the things that we're going to bring up here tonight to sort of take things to the next level. But before we get started, I thought I would just start by asking the two of you a question I don't usually ask people, which is, what's it like to go to work every day? And, I think people sort of have a general idea that there's a lot going on at MD Anderson in terms of leukemia. I'm not sure everybody realizes that this is really the greatest concentration of academic leaders and investigators in leukemia in the world. They have 40 physicians focused on acute leukemia and of course, tons of other supportive personnel, just really incredible. So I just wanted to start, because I've never really asked anybody. I'll start with you, Naval. You were telling me that your new patient conference that you do every week, you cover like 35 to 40 patients, which is just, I would love to go to that conference. But anyhow, Can you just kind of give us a little bit of a glimpse about what it's like to work there, Naval?
Yeah, it's fantastic. Like you said, it's a unique place. There's really no place where we are able to kind of, make the degree of progress in clinical trials, research, translational, and also just being able to offer all our patients, pretty much every single patient, a clinical trial that we believe or is likely to be a standard of care plus, meaning something better than the standard of care, so maybe the future standard of care. So it's also a very, very busy place, and people would think, oh, with 40 faculty, we probably have a lot of support and coverage. But I think actually each of us is quite busy, either doing educational activities, a lot of clinical research, trials, education. So all in all, I think that's why you'll see, if you look at the history, the retention rate is amazing. More than 90% of people, stay on for 10, 15, 20 years. And that's a testament of the great leadership here, set up by Dr. Kantarjian, Emil Freireich before that, and then, continuing with many of us continuing to build new programs. So, yeah, it's wonderful.
Courtney, any thoughts, any comments about Dr. Kantarjian? I was asking you about him, and I was reflecting back on my first meeting with him. But any thoughts about working there in HAGOP?
Yeah, I'm certainly biased and very partial, but I think Dr. Kantarjian is the best chair. I think he has a very, it would be hard to imagine, having 40 different leukemia faculty, many of whom are, leaders in their own right, and he can, just manage this group well and make sure that everyone is always kind of like pushed just the right amount, not to the point of, breaking, but just always on your toes, always on your game. You mentioned the new patient meeting. We have, I think, 5 meetings on a weekly basis. So we have the new patients where we're going through all the ones that have come in on the outpatient and inpatient setting, making sure that, everyone has thought through what's the best trial to offer, a relapse patient with XYZ mutation, but also the complicated inpatients, those types of meetings, as well as kind of scientific discovery, internal and external presentations. It's a great place to be.
So, Naval, I was telling Dr. DiNardo, my first meeting with HAGOP was, I think it was almost 20 years ago. We had just been doing breast cancer, and then we decided to go out to all of oncology, and okay, let's go into hematologic oncology. So HAGOP was in town. We said, hey, come on over to our office. We'll do an interview. He sat down. I think I asked him in the hour and a half that I talked to him, I might have asked 5 questions. I was like, Dr. Kantarjian, what's new in CLL? And then it was like, boom, 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 15 minutes.
Yeah,
and what's new? It was like, really amazing.
It's still
anyhow.
Like that, he's still, if you ask him AML, and he likes to keep in touch with, I don't know, if you ask me nitty gritty of CLL, the last phase 3, I don't know all that stuff. I ask my colleagues, Nathan Jain, Bill Weirda, but he likes to be on top of every leukemia subset. So that's a thirst for knowledge. He has a great thirst for knowledge all the time, which is great.
And at the end of the day, he has the vision for kind of curing leukemia in all the different subsets. So that's exactly who you want to be leading a department like this.
Absolutely. So let's get into some of the papers and presentations that came out. Actually, quite a bit happened in AML this year. Naval really focused on non-targeted treatment, particularly HMA venetoclax and all the variations and work that's being done there. Courtney focused on the biomarker-directed targeted therapy, really so exciting. But before we get into it, I just want to kind of take a step back. And first of all, I want to ask the audience a question. As you know, our primary target audience are general medical oncologists, community-based practice, the docs who not only take care of AML, but bladder cancer, myeloma, breast cancer, et cetera. So audience, I would like to know, do you provide direct care to your patients with AML? And if you do, is it mainly or just the older patients who are not eligible for intensive chemo, or people who are both older and younger available? So, Courtney, I guess the reason I asked this question is I kind of feel like the general medical oncologist was kind of on the periphery of AML until, I guess it was 3, 4, 5 years ago when HMA venetoclax came out. And all of a sudden, they needed to know about AML right away. And now they've got some experience with that, and I think they're kind of on board in general with AML, and I think targeted therapy they're starting to utilize. Any thoughts as you've seen this process, Courtney? I think 4 or 5 years ago, most of these patients, particularly the younger ones, were getting treated, even intermediate young, 60 to 70, in tertiary centers, but I'm not sure what's going on right now. I think a lot of general oncologists are taking care of these patients. Any thoughts, Courtney?
Yeah, I would agree with that. I think more and more AML patients, both younger and especially the older patients, getting lower intensity combinations are being treated in the community, and I think that's really important, right? Because a lot of those older patients maybe never went to the big clinic in this local city that was 3 to 4 hours away, and so there's more patients getting more therapy, appropriate therapy in their hometown, and I think it's the onus is on us to make sure that the community knows all about these new different therapeutic options and how to best manage them and how to be aware of all the rare but important side effects and nuances, because I very much agree that more and more patients are being treated in the community.
So interesting. I'm actually kind of surprised about half of our audience answered 3. So we'll have to go back. I still think they're mainly general oncologists on the line, but I know there are plenty of oncologists who give 7 of those 3, but I didn't think there were that many, or maybe that's the kind of people who tune into this webinar, but interesting. Curious what the national figures might be on that. I definitely have the impression that everybody got on board once the Aza-Ven was here. Mm-hmm. So we're going to start out talking about Aza-Ven and HMA venetoclax. And Naval, one of the things, it was so exciting when these data first came out and people were going in response and it was awesome. But as time goes on, we started to realize that maybe, even though this is a great development, it really isn't necessarily doing as much as we'd like it to do. And this is the follow-up that you showed from the study. Anything you want to say about that?
Yeah, I mean, as you said, I think we all were very excited and are still excited about the potential of Aza-Ven. The response rates are great, CR rate and survival is definitely improved. So no doubt this has been a progress step in the right direction. But I think we all realized also that with long-term follow-up, this regimen is not curative in a large proportion of patients. So about 25% or so will have a long-term survival. But for others, we need to move beyond, whether that's adding something rationally to Aza-Ven and those with potential targets, or whether that's looking at other backbones to which Ven could be added. I think, we want to put the message out that, this is not the end of the research. It's kind of the beginning, first step of research to then build on, kind of like what was done with Revlimid Dex. And then now we have 6 drug combinations. So I think we need to keep moving forward in AML to higher cure rates.
Yeah, it looks like you all are moving pretty closely to triplets. Maybe you can get to quadruplets like myeloma at some point in time.
We may.
Courtney, again, getting back again, Courtney, to what happens to people and who are treated. I guess one of the things I've heard a lot of discussion about, again, is the sort of intermediate age, 60 to 70. How are you determining now, and how does that compare to when Aza-Ven or HMA-Ven first came out, in terms of how you're looking at who's qualified? I kind of get the feeling that maybe more HMA-Vens being used in those intermediate than maybe 4 or 5 years ago, but what are your thoughts?
Yep, no, I think that's definitely true. And that may be why more patients are being treated in the community than were being referred before, because initially we used Aza-Ven for patients who were really unfit for intensive chemotherapy, because the curative option and really the only good option was intensive chemo. But given the effectiveness of Aza-Ven, as you can see, there's a clear separation of curves. These patients are doing better with Aza-Ven. And then you start thinking, well, gosh, if my patient can obtain a remission at the same likelihood with Aza-Ven than with intensive chemo, maybe I'm going to opt for Aza-Ven. But I think the important thing to remember is that Aza-Ven is not curative. So you don't want to give a younger, fit patient who could get intensive chemotherapy Aza-Ven unless you're going to follow that with a transplant. Because as you're seeing in this curve here, there's still this ongoing tail, and we're not kind of truly curing the vast majority of patients. But I think your point is very well taken, that, we are kind of giving Aza-Ven to younger and healthier patients than we were before. So those, 60-year-old patients, that this is something that is considered.
So at Naval to talk about this slide, because it really was interesting, and I had not seen that broken down. But first, a couple quick questions from the chat room to Courtney, just to follow up what you just said. Muhammad wants to know what kind of antimicrobial prophylaxis you use with Aza-Ven, and also how do you dose Ven in subsequent cycles depending on cytopenias? Number one question about Aza-Ven is cytopenias in general. So any thoughts about that and prophylaxis for infection, Courtney?
Yeah, the average patient, we usually give 3 weeks of venetoclax and then 2 weeks off. So they end up being about 5-week cycles with 21 days of Ven. Sometimes that's kind of the perfect tempo for a patient. Sometimes even with that, they're still having persistent neutropenia or thrombocytopenia. And so Ven 14 days duration is often done. And I see that more and more as we realize that the continuous venetoclax is not really needed to have favorable outcomes. In terms of antimicrobial prophylaxis, we typically use a fluoroquinolone, so Levaquin. We here in Houston kind of live on a swamp, and we see a lot of fungal infections. And so we do recommend a mold-active azole, so posaconazole or voriconazole in our patients that are neutropenic for the first few cycles, and antiviral.
So Naval, Muhammad, who seems to have a lot of questions, also wants to know, do you always start at full dose with everybody of venetoclax? Another question from Muthu is interesting. Are the remissions obtained with Aza-Ven versus intensive chemo morphologically the same? Do they do as well after transplant?
Yeah, so both good questions. So the first question, we do tend to start with, well, the goal is to go with the full dose ven. So we do a ramp up, if that's the question. We are continuing to do that for our patients, as was done in the phase 3 and per the label. So if we're going to go, for a patient on, let's say, voriconazole, we usually would start with 20, next day 50, then 100, and then stay at 100. But our goal is to get the target dose of venetoclax in. What we manipulate or adjust more for count recovery is the duration. So we cut down the days from 21 to 14 to 10 to 7, but we don't change the dose at the same time. So dose stays same, duration comes down for count recovery. The second question is a very good one, and something we kind of, we don't have prospective randomized data, but we looked at this exact question about a year ago. It was published by Dr. Kadia and Bazinet from our group, where we took patients 60 to 75, all of them who went to transplant, and then we split it out by the regimens they received. So about a third got intensive chemo, about a third got HMA-VEN, and about a third got a regimen we'll talk about called cladribine, low-dose Ara-C-VEN, triple nucleoside regimen, we call it. And the goal was to say, okay, all of these people achieved a CR/CRi, but was there something qualitatively different or special about intensive chemo because it's intense? And actually what we found was the reverse. The people who did the best post-transplant were those who got cladribine, low-dose Ara-C-VEN. The second was HMA-VEN, and intensive chemo actually did a little bit worse. So in fact, it looks like the quality of remission may be similar, and patients going to transplant after lower intensity are probably in a better physical condition, more robust, less comorbidities, and seem to have a better outcome post-transplant. So the answer is, if you're going to go to transplant, that should not necessarily make you choose one regimen or the other. You can have a path to transplant effectively with any of them regimens.
I don't know what's going on in the chat room. Somebody must have put some espresso in there. They're just pumping them out. Thoy wants to know, well, this is one I hear a lot. Again, back to you, Courtney. When do you do the first marrow? Do you do it on the first cycle?
We do, but typically a little bit earlier. So around about day 21, somewhere between day 21 and day 24. And we do that because you can usually get a prelim within a few days. We're fortunate we get it within 24 hours. And that way, if the blasts are less than 5%, we can hold the venetoclax on that day. So like day 22, 23, 24. And it just allows them to recover a little bit faster so that you're kind of on schedule. With what usually ends up being kind of that 5-week cycle.
So if anybody in the chat room wants to ask whether or not you can stop venetoclax, hold on, we're going to get to that in a minute. But I would love you to go through this briefly, Naval, because I don't remember seeing a breakout this way, and it's very interesting in terms of how the aza-ven data were looked at and what you saw there.
Yeah, sure. I mean, there was actually a paper before by Andrew Way and Courtney in our group looking at kind of the phase 1b molecular determinants, and kind of was similar, but obviously smaller numbers. Now, this is a bigger analysis that the ELN group that everybody's heard about kind of did on the VIALE-A large 400 patient study. And, they had a robust number of samples. They did molecular next generation sequencing on all of them. And they basically kind of did a very simple bioinformatic analysis to say, okay, based on these 200 and whatever patients who have received HMA-VEN, 279, what bioinformatic molecular determinants can be predicted for prognosis. And what they found was kind of, I think, something that we had started to see in the phase 1b and knew intuitively was good to show objectively was TP53 does really poorly, median survival 6 months. One can argue that it may not do much better than HMA alone. There is a slightly higher response rate, but survival is about the same, 5 to 6 months. And then you have the second group, what we call the signaling kinase mutation population. So these are FLT3 ITD RAS mutations without a TP53, which is about 30 to 40% of frontline AML. So it's a big group. Median survival here is about 12 months, a little better than what you get with HMA alone, but still a room for huge improvement, unmet need. And then the third group is those who do not have a TP53, FLT3, or RAS. So this is really enriched with NPM1, IDH1, IDH2, RUNX1 splice mutations. And this population tends to do, in general, better, higher benefit. Doesn't mean that you cannot improve them further. It's just that you need to know that the bar is already higher. So if you add a drug, it should not have too much cumulative toxicity. So I think this is going to be really important from our perspective, at MD Anderson for developing combinations, because we cannot just take all comers and say, oh, this triplet is better or not. You have to put it in the specific molecular group so you know what would be considered an improvement for a FLT3, for a RAS, and so on and so forth.
So I had to take a deep breath after I saw this one, Courtney, but maybe I imagine you could probably spend an hour talking about that. But some of the things that I recognize down there to the left, FLT3, KRAS, BH3, are a few things at least I recognize. Any thoughts about what's the main issue here or how to attack it?
Yeah, so what you just saw on that last slide shows that there's kind of two different main groups of patients who are not doing as well. And so one of them is P53 mutated. So that's kind of on that top right, that number 2, which is a big problem, right? P53 mutated patients just don't really benefit from any of the new therapies that we have, including, unfortunately, Aza-Ven, their survival is still 6 months or less. And then the other group are those signaling mutation patients. So what, Naval was just saying, the FLT3 ITDs, the KRAS, NRAS, the signaling phenotype, which often overlaps with monocytic disease, which also overlaps with overexpression of MCL1 and BCLXL and the kind of other families, other than BCL2. So kind of 1, 5, and 6, those numbers are all interrelated, which are those kind of signaling mutations when you're doing the NGS panel that you can identify. So these are kind of the key resistance mechanisms, and where we're kind of most hopeful that adding therapy to the Aza-Ven backbone will improve those outcomes in patients who are not deriving the most optimal benefit.
So we're going to move to a lot more practical issues, and here's a huge one. Oral decitabine with venetoclax. I mean, there's an obvious thought. Obviously, we're using oral decitabine in MDS, and patients are able to benefit from it. But you all have done a lot of work looking at this combination. Naval, can you kind of summarize what we've learned or what you learned?
Yeah, sure. So this is a combination of, as you said, oral, obvious benefits, being oral therapy and not needing IV infusions. And we were, I think, the first group to start looking at this. We used, as you said, the oral decitabine approved regimen from frontline MDS, 5 days, with venetoclax, very similar from the VIALE-A. And as you can see, overall response rates were very similar to the VIALE-A in the 65-70% range, with the CR rate almost exactly the same, 36-37% VIALE-A. The OS is a little lower, and a lot of people ask us about that. But the reason is this was a older population. The median age was actually about 81, so about 4 years or so older than VIALE. And the second is we did allow secondary therapy-related AML in this population, which was not allowed in the other study. But actually, when you take out that population, and this was shown at the ASH meeting, then the survival is the same. So I think good option. Obviously, there are larger studies ongoing, will hopefully be presented and will lead to maybe potentially full label NCCN guidelines. But I think this is going to be one of the ways to go. I do want to caution a little bit here that even though this is oral, it does not make it less myelosuppressive or better tolerable. So we still actually admit our patients for this regimen as we do for IV Aza-Ven, and we still monitor in that first cycle as we would do with IV Aza-Ven for the first 3 to 4 weeks. We do the tumor lysis, the hydration, the antibiotics. I think after cycle 1 is really when this regimen gives the most benefit. You can have people outpatient. You can do labs once or twice a week. They don't have to come for IVs 5-7 days in a row. But you still want to, think of this as Aza-Ven from a toxicity perspective.
Yeah, getting ready for the oncology nursing meetings got my head really filled up with the issue of adherence and assessing adherence and encouraging it, which obviously is so important, particularly in oral medications. But I mean, Courtney, it seems like a huge benefit. We've seen having gone through COVID, not to mention, which I think even sensitizes us more to keeping people out of the clinic. I kind of am surprised it's not available right now. That I know there's obstacles to get it outside, because it's not approved. Do you have any hesitation about using it right now, Courtney? Is it mainly difficult to access, or is there any concerns?
I think the main issue is access, right? It's approved for MDS right now, and it's an expensive oral outpatient medication. to get through specialty pharmacies. So, I think there's a multi-center study of oral decitabine and venetoclax that is ongoing right now that has just completed enrollment. So hopefully we'll have results of that soon. And then once that story is kind of more publicized, I anticipate it will be used more frequently. I certainly don't have patients in the clinic saying like, I would prefer an IV therapy, right? When you give them the option of all oral versus IV, clearly the patients prefer. I think Naval's point is important, right? Just because it's an oral therapy doesn't mean it doesn't have side effects. So you do still need to be seeing patients for labs and transfusions, and so I think that's an important piece. But no, I think I think this will have increasing kind of uptake and use probably over the next year or two.
I'm kind of curious, Naval, do you think that one, obviously we're adding things to HMA venetoclax to try to improve outcomes. Do you think that future trials or even ongoing trials, will they differentiate whether it was oral, aza-ven or not? Or you think it'll be considered either way?
No, I think, I think a lot of people may extrapolate, eventually, and let's say aza-ven gilt, becomes more and more used. And then we do have a study actually that we're looking at with oral ven gilt. And what I will say is with some of these combos, we do see more myelosuppression with the oral decitabine, right? And that comes into play even more when you add the third drug. So I do think we need to have at least dose-finding data because I think we may actually eventually be using less oral decitabine than the 5 days, maybe 3 days in the beginning where some of our studies were looking at that. So I do think that I would be cautious to do a 1:1 extrapolation. I think we need to have separate studies with the oral versus the IV to make sure we're getting the optimal regimens for each.
So we brought up the issue of stopping venetoclax, and we saw Naval went through this paper from the ASH meeting looking at the stop-ven study. Can you summarize what they did there, Naval? And then I'm curious from Courtney what her thoughts are about what she does in her own practice and in trials. But can you talk about what they did there, Naval?
Yeah, sure. So this was a presentation by the French group combining data with the Moffitt group, where they looked at patients who were on aza-ven who had achieved a CR or CRI and had been on treatment for at least 3 to 6 months or longer, and decided, this was retrospective. So physicians or patients decided at some point to stop treatment for various reasons. Prolonged cytopenia was the most common reason, but other reasons were patient preference or distance or logistics or finances. And basically the question was, is this safe? What proportion will relapse? What they showed was that actually in patients who achieved a CR or CRI, if in the frontline setting, especially they had both the frontline and relapse refractory cohort, but in the frontline setting, the median survival was like 45 months plus. So it did seem to be an effective strategy in selected patients, confirmed CR, CRI. And more so, if you have MRD data, then that can really help boost the confidence if this is an approach one may consider taking. They showed that those who are MRD negative in the newly diagnosed AML setting after confirmed CR/CRI, stopping treatment, the median survival had not even been reached. So we still don't recommend this today because there are still patients who do relapse. It may not be the majority, but there are 10, 15, 20% we have seen even after a year who could relapse. Other groups have seen this, but if there's no option for whatever reason, the patient cannot come, money, insurance, toxicity, myelosuppression, one could consider this kind of in a very safe approach with bone marrow monitoring, and there may be some patients who could benefit long term. But yeah, Courtney.
I wanted to ask Courtney about one other issue related to venetoclax, and then I want to move on and talk about a lot of cool stuff going on in terms of targeted therapy. But Courtney, of course, we're adders in oncology, and naturally we added ven to aza. That looked good. Why not try it with intensive chemo? It seems like it's being done with every possible type of intensive chemo. Any sort of global thoughts about this, Courtney? Do you think in a couple of years we're going to be adding ven to intensive chemo in younger patients?
I think we might be. So I think what is it when you're giving intensive chemotherapy, right? That's where the original classifications, that favorable, intermediate, and adverse risk groups were first made, right? So there are patients who have particularly favorable disease, like the core binding factor leukemias, dual mutant CBP alphas that are really have a high likelihood of cure with standard intensive chemotherapy alone, don't need a transplant. probably don't need the addition of venetoclax. For the intermediate and especially the adverse risk, that's where we've seen the addition of venetoclax has really improved the outcomes, the initial response rates, the durability of response, the success in getting people to transplant. This is all in kind of single institution phase 2 studies right now, and there are registrational phase 3 studies looking at intensive chemo with or without venetoclax. I think there's these two groups that won't benefit from that, the favorable risk core binding factor patients we just talked about, and then P53 mutated patients. They don't do as well with anything. Intensifying their therapy by adding venetoclax is probably not helping. But for the rest of the group, we really do seem to see kind of deeper remissions and potentially improved outcomes with the addition of N.
So one final issue I wanted to ask about. So you can imagine how often we're talking about antibody drug conjugates and solid tumors, but you all really started the show, and it sounds like you got some new things coming in here. CD123 pivekimab, I'm not sure if I pronounced that correctly, but we're seeing some wild, really great stuff in solid tumors with ADC. Naval, any thoughts about this? And there's a couple other ones too.
Yeah, no, as you said, I think ADCs have, been of interest in acute leukemia and in CLL and other groups. And, we have a number of them approved, gemtuzumab for CD33 and AML, but then also inotuzumab, for example, in ALL, and myeloma, as you mentioned, has a number. So, I think in the last 15 years, we've been making a lot of efforts to move beyond gemtuzumab. It has some activity, but also has a lot of toxicity, VOD, myelosuppression. The toxin is not what we would like to use in the modern era, calicheamycin. So pivekimab kind of checks a lot of those boxes. It has a better toxin payload, single-stranded alkylating DNA break. It does not seem to carry the baggage or risk of VOD. It does not seem to have the issues of capillary leak, as has been seen with one of the other CD123 antibodies. So all in all, we've been pretty excited about this agent. Single agent had some activity, about 25% or so CR/CRI, but not sufficient. It was felt to go for full approval. So we've moved it up front in combination with Aza-Ven, just because we need to improve the outcome as we discussed. And it looks really good with this combination, not seeing too much cumulative myelosuppression, less than some of the other triplets, with very good upfront true CR rates in the 55-60% range. So, of course, this is going to need randomized long-term study. And also this drug is being developed in BPDCN, blastic plasmacytic dendritic neoplasm, where we are hoping potentially it could have an early approval, potentially as early as next year, based on the emerging data. So, yeah, I think this will be a nice addition, and there are many other ADCs that are entering the space, kind of a resurgence in AML of various ADCs in the last couple of years.
And Naval, I know one of your great interests is immune therapies. Actually, I found out by looking at your website, I didn't even know Courtney's into hereditary AML, et cetera. But I don't even want to bring up this NK cell engager. Watch the talk and let him explain what this graphic means. But we're not going to do it now. But that's I don't know if it's a bispecific or a trispecific, but a pretty interesting agent that actually seems to have some activity as well. So let's talk about targeted therapy, or what we thought was targeted therapy, but maybe not quite as straightforward. Beginning with FLT3 and an update to the quantum study. Courtney, of course, indirectly we're thinking, already you have midostaurin on board. Now we have two agents in a similar space, and everybody's asking the question in terms of comparable, which of course we only have indirect comparison. But we did see an update to the quantum first study. What were your thoughts about that, Courtney?
Yes. So I think, the differences between 7 and 3 with midostaurin versus 7 and 3 with quizartinib is to remember that quizartinib is specific for FLT3 ITD. So your patient has to have a FLT3 ITD. If they have a TKD mutation, which is the D835, usually that patient is going to benefit more from midostaurin. But with quizartinib, the other thing, You're not showing the slide, but I talk about it in my talk, that there's kind of this comparison, and people are kind of looking and saying, oh, this curve looks just about the same as the midostaurin one does. I'm not so sure quiz is any better. And I think it's important to remember that, again, with this study, it's only ITD mutated patients, which these patients do worse than the TKD, which is less kind of adverse risk. And also this study enrolled patients up to the age of 75 if they were fit for intensive chemotherapy, where the original RATIFY study for midostaurin only enrolled patients up to the age of 60. And so if you're really trying to compare these two studies and look at just those patients under the age of 60 who had ITD mutated disease, it does look like quizartinib is a very, strong contender for being the more potent FLT3 inhibitor. And so I think that's just important to remember when you're trying to eyeball the two graphs and figure out which is better.
In your summary slide, you also talk about MRD, which is really seems to be like an increasing issue in general with AML, including here.
Yeah, and that's exactly what I was going to mention next, which is, in the RATIFY study and many of our older AML studies, we don't have MRD data because it wasn't a thing yet. But now we're realizing, how important it is to not only have kind of your pathologist tell you the leukemia is in a remission, that you're looking at it and you don't see leukemia, but kind of to deeper levels of, sensitivity to 10 to the -5, -6 with these very sensitive assays. If you've cleared that MRD, that residual FLT3, your patients are going to do better, longer, more durable remissions and improved overall survival. And that was seen in the patients receiving quizartinib.
So Naval, for practical purposes, one of the things our audience is interested in is you now have two options, and at least for ITD patients. I'm curious if you have a preference, also in terms of, and what's your view indirectly comparing efficacy, but particularly tolerability. Courtney was saying that some of her patients call midostaurin the skunk pill because it doesn't smell very good and maybe causes GI issues. But when you put it all together, how do you compare the two, and any preference outside of trial, Naval?
Yeah, no, I we and me have a very clear preference with quizartinib for many reasons. I think that's one that I can kind of be more definitive because it's a second generation drug. It was developed always as the more powerful later entry specific for FLT3, whereas midostaurin was actually developed as a multi-kinase inhibitor for solid tumors and then kind of didn't work there and repurposed. And it was great for a while, but I think we were always waiting for the second generation. And then, as you mentioned, I think tolerability is really critical. And if you ask patients, many of them, leukemia AML patients will take whatever we have to give them because they know this is a matter of life and death, literally. But if you really ask them, yeah, they do have a lot of issues, GI with midostaurin, and taste of smell, taste, nausea, GI problems, which we have not seen with quizartinib. That being said, we do have to monitor for QTC with quizartinib. It's not something that causes patient discomfort, but it is something we have to watch out for because if left unmonitored with many cumulative QTC prolonging drugs put on board, you could run into problems. Although clinically, this is something we have not had issues with close management. And then efficacy, I completely agree with Courtney. When you really try to look at it apples to apples in the 18 to 60 population, and ideally considering that these are all ITD, higher risk group, I think you're seeing a better survival actually overall at 4 years, closer to 60% versus about 50% with Mido. So yeah, I think even though there seems to be a debate, I personally feel, and I think many centers are moving with quizartinib up front today.
So next question, I'm going to start by saying, I'm curious, Courtney, have you ever heard about HER2 low in solid tumors? There's now a pan-tumor approval for TDXD, and in breast cancer, they give it to HER2 low. The only reason I'm bringing it up, completely different disease, completely different scene, but I was pretty surprised when I saw HER2 low, thinking it was a HER2, drug. Now, the Kiwi study, FLT3 ITD wild type benefit seen there, and a FLT3-like signature. Yes. That is where the benefit is. And this is a lot of people, right? Like maybe a quarter of AML has got this. So now FLT3, adding this up, now you're talking about half of it. So here it is. Yep. Any thoughts, Courtney?
My initial thought is a little bit of like, I'm not quite sure what to do with this yet. A longer thought is, it makes sense, right? Because these are kinase inhibitors, and there may be people that have this kind of activated profile that don't have a specific FLT3 ITD, but that may benefit, right? And so what this is saying is that there are patients who don't have a FLT3 ITD, but yet they have this gene expression signature that suggests they're going to benefit, that they look like they have a FLT3 ITD. And about, in this clinical trial of patients that were receiving 7 and 3 with quizartinib who didn't have a FLT3 ITD, that half of the patients had this FLT3-like signature, and those were the patients that benefited from the addition of the quizartinib. So it makes some sense. It reminds me a lot in our world of leukemia of the PH-like patients that don't have a Philadelphia chromosome, they don't have that BCR-ABL, but yet they have this expression profile that suggests they would benefit from the addition of a TKI. So the challenge, though, is that we don't really have this expression analysis able to be used in the clinical setting in real time to decide who should or should not receive this therapy.
I just flashed on another example. I don't know how close you are to the GYN people there with Shannon Weston, but, for PARP inhibitors, obviously we have BRCA, where patient responds, but there's another thing we have called a loss of heterozygous score, like scarring or something. I don't know how they do it, and these people respond like PARP. It kind of seems a little similar.
Yeah, and I've heard Shannon talk about like a BRCA-Ness phenotype, right?
Exactly. Yes,
actually the same thing. Yep.
All right. Well, at least it's something familiar, although it's pretty interesting, and I wonder where it's going to lead. This is Naval also talked about in his talk, but it's just really so cool. It's great to go back and take a look at this. Another super interesting data set, the Morpho study, looking at gilteritinib after transplant. And just to point out, and Courtney, if you can explain what they did here, but just to point out, right at the top, I noticed that it's only for ITD patients, even though it's gilteritinib. But you said that's because of the MRD assay they were using, or what did they do? Go ahead.
Yeah. So this is a post-transplant study, right? So FLT3 ITD mutated patients have the highest risk. One of the higher risk, they're the adverse risk group that are more likely to relapse post-transplant. And we have this, fancy, very sensitive MRD technique now of looking, to a level of 10 to the minus 6, have we cleared that FLT3 mutation? And so what this study did is it looked at, whether or not placebo versus gilteritinib for 2 years after transplant. You started it as soon as you could post-transplant, 30 to 90 days after, to see if you had an improvement in relapse-free survival. And shown here, the primary endpoint was just shy of being significant, 0.0518. But it kind of showed what you would anticipate it might show, and really, again, highlights the importance of MRD, right? So in that top curve, in patients who were MRD positive, either right before or right after they went to transplant, if you could detect a FLT3 ITD mutation, those were the patients that benefited from adding gilteritinib, whereas, the patients who didn't have any residual FLT3 detected at an incredibly sensitive assay probably didn't need the addition of gilteritinib.
So really an amazing story. Are you applying this in your practice, Courtney?
Yes, with the caveat that I'm not a transplanter, but yes, we are working very closely with the transplant team and really trying to prioritize, MRD testing of our patients peri-transplant, as well as rapid initiation of FLT3 therapies post-transplant, because the other thing that is highlighted is, how quickly these patients will relapse. So if you're waiting for, a perfect opportunity where, 6 months, 9 months later, it's too late, the patient will have already relapsed. So you really want to start it as soon as you can post-transplant.
So picking up on another common question, I don't know if we saw any important data this year, but it is a question a lot of people have, is the patient who's not eligible for intensive chemo novel, but who has either a FLT3 or IDH mutation, in terms of whether or not to include targeted therapy up front, for example, in a triplet. I kind of am getting the feeling that that's the direction things are heading, but are we there? And do you expect us to get there, Naval?
Yeah, I think we're getting there quickly is kind of how I would put it. And for FLT3, especially, there's obvious huge unmet need given that the median survival is only about 12 months with Azaven, as published by Marina Konopleva from our group. So we really need improvement. And we just published the Azaven with the gilteritinib data by Nick Short and us in JCO, showing that the 2-year survival was about 65% compared to around 25% with Azaven. So yes, single arm, and we do have to adjust the doses as in any multiple combination regimen, but it seems to be quite effective. And also in our experience, once we optimize the dosing, was actually quite tolerable without very prolonged myelosuppression, early mortality, toxicity. And the same is being looked at with Courtney in our group in IDH, with the triplets also showing very high efficacy, although there, of course, the AZA-IVO survival is already 29 months, so we have to get more mature data. But I do think we're going to see in both those subsets, eventually with dose optimization, like we do in multiple myeloma and lymphoma and ALL, we're going to use all the effective drugs optimally up front, and then potentially maybe something even for the menin inhibitors in the near future.
So, Courtney, I've classically always argued with myeloma people because, in solid tumors, if you have a non-curable situation, you do single agent sequentially, breast cancer classically. As Naval was just saying, myeloma evolved into everything as much as possible. Not sure they have as much data as they would like, but they have strong feelings about it, that's for sure. I'm just curious. I mean, it's a classic question in oncology. Should you use Azaven and then follow it with targeted therapy, or give it all at once, and then maybe your second line therapy is going to be compromised in the long run? Now you're talking about AML too, that has a pretty acute history. Maybe you want to get going much quicker than, say, myeloma.
Yep. I think, the challenge with sequential therapy and doing Azaven up front and waiting for relapse and then using a targeted therapy is that we now have an increasing body of literature showing us that patients who fail Azaven, even if they have an available target, do really poorly. The median survival is like 6 weeks when people fail Azaven. So waiting for relapse is maybe not the best strategy if there is a way to safely add things to a more effective, upfront therapy. Because you're right. I mean, if we are, causing a lot of myelosuppression and toxicity and people are not doing well, then that's not the right strategy, right? But that's what we're trying to figure out is, can you kind of fold in a well-tolerated targeted therapy into the Azaven by attenuating the AZA and the venetoclax in particular to make it well-tolerated, more people respond, and those responses last.
So I've been hearing about menin inhibitors for a while, but it sounds like it's time, that it's going to be happening soon. And I was actually, some of the most things I learned the most is in the time prior to these webinars when I get a chance to chat with you. And I have to say that I was actually concerned when I chatted with you all about this, about your concerns about these agents that are about to come into practice and whether or not we're kind of ready for it. So we'll get to that in a second. But first, we were talking about mechanism also before we got started here, and that's something we could do for hours and hours. But you want to take a shot at kind of explaining how these agents work, what the targets are, what the likely target will be for the FDA approval that's expected maybe this year, and your vision about how it's going to go.
So menin inhibitors, I think, are the next new thing for AML. So these are small molecule therapies. They're pills, and they are not cytotoxic therapies. These are differentiating agents that kind of bind to the menin protein and break apart this complex that is leukemogenic that causes a block in differentiation. And so you're seeing, when you use these menin inhibitors, if you have this activated what we call the HOXA9 or the MEIS1, this program that is causing a block in differentiation, these therapies work really well to turn that off and allow normal myeloid differentiation to proceed. So this is primarily, and was initiated, the clinical trials in 2 different disease subtypes within AML, NPM1 mutations, and KMT2A rearrangements, with KMT2A formerly being called MLL. So when you see like MLL translocations or 11q23 translocations, that's KMT2A now. So those are the two groups where the initial clinical trials with these menin inhibitors, and there's now a handful of them in trials, have been initiated, and we're overall seeing kind of good results similar to IDH inhibitors or FLT3 inhibitors in the single agent relapse setting, with kind of about 30% of patients responding, those responses being reasonably durable, improving outcomes, and probably new approvals coming soon.
So again, we were chatting about mechanisms and also differentiation syndrome, which is an issue with this as it is with IDH inhibitors. Before we get into the clinical part of it, just to come back to this graphic you have here, I don't know, I hear differentiation syndrome, I think about IDH. Are the mechanisms, the pathways related in any way?
Yes,
Courtney?
they are related, but they're not exactly the same. So, the IDH mutations are are mutations within the Krebs cycle. These are metabolic enzymes, the isocitrate dehydrogenase, and the mutation causes this kind of oncogenic metabolic enzyme that causes chaos, but in an epigenetic fashion, right? That is causing a hypermethylated phenotype. And so this is also causing kind of this epigenetic abnormalities through the PRC complex. And so I think it's probably more nuanced than we need to get to, but in general, yes, it's an overall epigenetic mechanism leading to differentiation blockage.
So discussion to be continued, but I'm glad this slide has a red background because I came up with a big red flag after talking to Naval, who's concerned about whether or not people who don't see AML all the time are going to have problems with these menin inhibitors in terms of differentiation syndrome. So Naval, this is more difficult to manage than IDH differentiation?
Yeah, I think what I want to really highlight is that you need to be aware of differentiation syndrome with menin inhibitors. It's seen with pretty much all of them. However, the kinetics, the frequency, and severity is actually different between different menin inhibitors. And a lot of this data is being published, peer-reviewed, and a lot of reviews and guidelines coming. But I think the point is, if you're going to start with these drugs, I feel people get a little bit relaxed and complacent when something is oral and they feel like, oh, we can give this and get labs in 2-4 weeks. You cannot do that. We do see some patients, it's not the majority, but we do see 5 or 10% where the white count can go up very quickly, come in with pulmonary issues, liver issues. And the nice thing is that actually if it's picked up early in the first 3 to 4 days, you can actually give them steroids and get it down, almost 100% respond within 48 hours. So I think we do want to be aware. It is more severe. We have seen more severe cases than IDH, natural arsenic. It is quite manageable. So just make sure that you kind of read about the label and the guidelines, before using it. Or if you're not comfortable, maybe a good patient refer to initially start with the treatment.
I don't know if other oncologists do the same thing, but if I hear about a biomarker and I don't know if there's any drug for it, then I usually don't remember it. So KMT2AR sounds like something we're going to have to start remembering, at least as it relates to this. And of course, it's being combined with azavenetoclax, and that sounds like an interesting option as well. And this is just some of a summary that came out of Courtney's talk. I want to talk, though, about IDH inhibitors. We referred to that a couple of times. This is Courtney went through a paper looking at oral decitabine venetoclax with ivosidenib. Again, the sort of triplet approach. Anything you want to say about that paper in general, these triplets and triplets with oral decitabine cetirizine?
Yeah, I would say, that we talk about triplets a lot, especially at MD Anderson. We're really prioritizing and rolling out a lot of these trials that not all triplets are the same. So it really depends on what the third agent is. IDH inhibitors in general are not very cytotoxic, don't cause a lot of myelosuppression. So these tend to be fairly well-tolerated triplets compared to, some of the others that cause more myelosuppression. And the whole point, you could argue that IDH mutated patients do pretty well with AZA, and do you really need a triplet? But to the conversation we were just having, with azacitidine and venetoclax, about 2/3 of patients respond. With azacitidine ivosidenib for IDH1 mutated patients, about 2/3 of patients respond. In this study looking at frontline populations where, more than 90% of patients are responding, and more than 80% of those responses are MRD negative. So if we can show this with more patients and with more time, that we are getting more patients in deeper remissions, then maybe that's going to lead to improved outcomes, in the long term. So I do think that these triplets, even for IDH mutated patients, especially IDH1, is important.
So our webinar attendees know I'm really into cool trial names. I love the all oral save idea. Yeah. Actually, you could maybe call it RVD light or new, revumenib, decitabine venetoclax.
Oh wow, that's a good one. Look at that.
RVD AML. So
the only problem is myeloma, guys. The myeloma may start treating our leukemia patients. You know how they are.
Yeah. So here's something else I was really curious about. All of a sudden, I forget, not too long ago, email came across our desk that there's another IDH inhibitor out there. I'm already coming up with the nickname of Oluda. But Courtney, I'm curious that, interestingly, we kind of a lot of times think all these things are the same, but I'm not so sure that's going to be the case here, because it looks like when you indirectly compare it to ivosidenib, at least particularly the duration of response seems greater. Any thoughts about this new agent? Can you envision, a better IDH inhibitor, mechanistically?
Yeah, I mean, that's really the million-dollar question, right? When you look at this slide, and the response rates are about the same, kind of overall response rate, complete remission rate, composite remission. The percentages are not so different, but what's really different is the durability. So the question is olutasidenib kind of a better IDH1 inhibitor? Is it kind of binding in that pocket and staying better, or is it just these are two different, kind of slightly different patient populations that were enrolled, and the ivosidenib patients, had higher risk disease, which when you look at the detail of it, they did tend to have higher risk disease. That twice as many patients were P53 mutated, more patients were relapsed refractory, multiple lines of therapy, had failed a prior transplant. So it's just hard to know because we don't really have any true comparison data. But olutasidenib, we're using more and more since the approval, and it is very well tolerated. And it does, have, I have patients in the clinic with very durable outcomes on olutasidenib, even from the original trials as the monotherapy. So I do think there is Oluta is a great IDH1 inhibitor.
So Naval, I'm curious about your thoughts. I was talking about the pan-tumor approval of TDXD, and now we were talking about, targeting IDH, obviously, and has been an issue with gliomas for a long time, but now biliary tract cancer. You're saying, I asked them, do you know anything about Oluda? The biliary people didn't know anything about it, but that'll be interesting to see whether they study it there. Any thoughts about this novel right now? Do you prefer Oluda if the patient's not going to go on a trial?
Yeah, I mean, I think this one is a little bit more nuanced than the FLT3 question you asked me, right? Where gilteritinib or quizartinib are clearly our superior drugs. But I think there may be something there. Like, we are, as Courtney said, the CR rate is a little better, the durations are a little better, the OS was a little bit better. What I think would be really nice is for somebody, whether it's the company or one of the, big preclinical translational groups, to take this and understand why. We know, for example, why gilteritinib, quizartinib are better. We know why ponatinib is better than dasatinib, than imatinib, and it's related to the binding, the crystallography, the mutations that cause resistance to one or not the other. We don't know that with Oluda. So I think that would be very nice, because if that is shown, then I think that could really help us feel more confident that this was a real biologically explained difference. Today, I would say yes, in practice, I'm comfortable to use Oluda. We do use it. And especially with IVO moving to the frontline setting, we do have relapse IDH1, where Oluda has actually shown activity post IVO in a small number of patients presented, I think, at ASH or EHA last year. So I think it's a good one for salvage options for today.
That's really interesting that you see salvage. A quick question from the chat room, Courtney. We were talking about these interesting data with the quizartinib and the so-called wild-type patients. Where do things stand in terms of the future quizartinib versus gilteritinib?
I might punt that one to Dauber. He might know more, but I mean, I think it will be a little bit harder to choose in the clinic if you have gilteritinib approved in the frontline. We're still waiting on the frontline intensive chemo with gilteritinib randomized study, because I think it's fairly clear, as Naval was saying, the tolerability of midostaurin is not great, but gilteritinib is pretty well tolerated. So if there's going to be kind of a future of intensive chemo with gilteritinib or quizartinib, that'll be a little bit more tricky, I think, to decide which one to use. Certainly, if they have a TKD, it's obvious gilteritinib is the choice, but for the ITDs, yeah.
Naval?
Yeah, I think it's going to be very interesting. I'm very enamored by this FLT3 wild type data. I think it's real. There will be studies coming soon that will hopefully confirm this in global settings. But I think we have to rethink, and the menin may be a similar story. With menin, we're finding a number of new fusions and targets that could be covered. So we may be pegging these drugs early on into smaller buckets than where they could work. So I think, we're waiting for some of the randomized data from GILT coming from the HOVON, and then we'll have to review it. But I think Quiz for now in the frontline space, especially with this wild type data, is sitting very tight as a good drug to be used up front.
Naval, do you know whether or not, or has GILT been looked at in FLT wild type?
It has. So yeah, actually we didn't go into that, but about 10 years ago, actually, both of these in the phase 1 salvage were looked at in the wild type in the dose escalation, and Quiz actually had quite impressive 30% CR/CRi as a single agent in FLT3 wild type. Now, this was at higher doses. We were going to like 120 and 150, 180, but there was this signal. And then, of course, we moved on, to the targeted therapy approach. And then GILT was looked at about 40 patients. It was only 8% response, so much, much lower than what was seen with Quiz. So, and similar with Midel, it had almost no activity in wild type. So there's something interesting about Quiz. There's other targets all of these drugs hit. So, for example, Sybil, KIT mutation, CSF3R, and actually a lot of labs, including some of the groups at MD Anderson, are going back to figure out what could be the wild type target beyond FLT3 here. So a lot of interesting stuff.
All right, really, I'm going to force myself to only ask one more question, which is, what about sorafenib? Didn't they see benefit with wild type there? And what about in that experimental system? Does sorafenib work?
Yeah, so sorafenib was actually the exactly same design study that was presented now by the Spanish. It was done actually by the Germans almost 8 years ago. Christoph Rohlig called it SORAML study, SORAML. And they kind of said the same. Let's use wild type patients, 3+7 with sorafenib versus 3+7 placebo. And they saw some signal for the relapse-free survival was like 22 versus 9 months, but the OS was not improved. So basically, the Spanish data just widened that gap and showed more clearly now, look, this survival is clearly improved. Kind of plays into the biology that quizartinib is a more powerful drug, but there may be something with the type 2 FLT3 inhibitors, both quiz and sorafenib, that we don't see with the GILT and Mido. So, yeah.
Interesting. All right. Well, thank you so much, Courtney and Naval. It's always great to speak with you. Audience, thank you for attending. Well, the entire ONS thing we're doing next week, if I can find it, is going to be, there you go, going to be online if you want to check it out and see what's going on in Washington, D.C. We're really looking forward to it. Be safe, stay well, and have a great night. Thanks so much, Courtney. Thanks, Naval.
Thank you.